you get my email? All right, so
That's fun.
orals. Yeah. So I just want to let you know I'll be there, but it'll be fine. It's only one, or is it two? All right. All right. All right. Cool. All right. All right. All right. I'll see you. Bye. All right. Great. All right. We ready to roll?
Yeah.
All right. So I don't think I have to introduce myself, do I? I don't think so. But if you don't know who I am, I recognize everyone, so.
Everybody, this is Doug.
Yeah, I'm Doug. So I stupidly told Matt that I do whatever he needed me to do, that I had tons of lectures prepared because I teach over in the nurse anesthesia program, and years ago actually helped start the program. So I got chosen to pick, talk about cardiovascular anatomy and physiology, and you have 45 minutes to do it. And I actually, as I put this thing together, it was a little bit of a struggle, like, well, what could we talk about for 45 minutes that would give some appreciation of this topic that could actually be a year's worth of classwork. So first of all, how many of you have had like an anatomy and physiology course? All right, so a third. All right, so that'll help. So that was the other thing. I was like, well, I wonder who has had what and what I should cover. So what I thought I would do is I put together a number of topics that are just kind of an overview. But I was trying to think of a lot of the times when we're picking up the phone and asking for you to come in and get us this, or help us with this line, or why did they call for 10 blood gases in the last 1 hour? Why do they care? So I was trying to kind of link it to a lot of the things that might occur day to day. So Gary had an interesting comment, because he or I first sat down, looked at the title, and he said, well, I didn't know I thought they didn't let you guys into the heart room. So I thought that was an interesting comment, because yes, in this institution, the CRNAs don't do hearts, but I do want to let you know that in our training, all of us had to do cardiac anesthesia, so that's part of our training. And the bottom line is, being in the heart room or not has virtually, particularly here, almost no bearing on this topic, given how sick most of our patients are. So we're all taking people back with various permutations of heart disease that we're dealing with in every single room in this OR. And the other issue is the very act of giving an anesthetic, the agents that we use. Almost all of them, do you need to come in? That's a lot. Hey Bob, could you come in? Almost all of them have some effect on the heart. So just the vaporizer, turning on the dial, shut the door, in itself has implications for how that heart is going to function. When we hang a bag of IV fluid, it has implications on the heart. All of the drugs in that drug tray, I'd say at least a third of them have some type of implication for cardiac function. So this is a big issue for anesthesia providers, having a very thorough understanding of how the heart works. And also, when we are calling you guys to help us set up a line, do this, do that, please, I need more ECG paper, which seems to be my favorite call. I'm sure you're like, oh God, he's on the phone again. It's because of all of the ramifications of stress of surgery and what giving an anesthetic does to cardiac function. So what I'm going to do is I'm just going to hit each of these areas, and then please stop me if you have a question, you think of something that may have happened in the OR, or why do you want this for that, and I'll try my very best to answer it in my 45 to 50 minutes. The other point that I want to make is that I will be saying a lot of what I'm not going to cover through this, because from what Matt showed me with the outline, there are going to be kind of spin-offs maybe from this lecture. So I'll kind of touch on it, and then I'll probably say, and you'll have a talk about that. All right? All right, we're ready to roll. All right. So first, the basics of anatomy. I don't have a pointer here, so I'll just point up here. The heart, even though we tend to think of the heart on the left side, it's really almost in the center of the chest. And the points here that I wanted to show you is its orientation, and it kind of sits and points down. We talk about the apex of the heart, which is really the bottom, and I always tend to think of apex as something like on the top. So this is the apex, and where the vessels are arising from the heart is actually called the base. So it's kind of the opposite of what might intuitively be how you would look at it. Here is the diaphragm here, and this surrounding membrane is the pericardium, which I'll show you some more in a moment. And then to orient yourself, if you're not familiar with the terminology that's used for anatomical terminology, this part is anterior and sometimes called ventral. So this is the front is anterior and the back is posterior or dorsal. So when we talk about the anterior aspect of the heart, it's this part, and the posterior would be behind what you're not seeing if you're looking head on to someone. So most of what you're seeing anteriorly is all the left ventricle. So this is almost all left ventricle here, which I'll have a few more pictures. And then just some fun facts to dazzle your friends with at a party. Okay. So the heart has a two-layer covering. There's actually a thicker fibrous membrane called the fibrous pericardium, and then within it is kind of like a folded thinner membrane called the serous pericardium. And this is kind of showing you a cross section. So within that, there's like this kind of tougher membrane that goes over it, and then within it, a folded membrane. One layer is actually adhered right to the heart, and then the other layer adheres to the tougher membrane, and within that is just a little bit of fluid, or pericardial fluid, and there isn't much. And that is kind of the lubrication. So it kind of allows a almost frictionless environment as the heart is beating. And so what I'll try to do is, as I go through, on my list of things to cover was hit on some cardiac disorders, cardiac diseases. Again, many quarters of lectures for each one. But one thing that you may have helped out with, particularly in the heart room, is if someone has pericardial tamponade, that would be the collection of fluid within these layers. And so as that area fills with fluid and expands, it impedes the normal function of the heart. And depending on how rapidly it accumulates or the volume can be catastrophic. And someone that has pericardial tamponade is a very difficult anesthetic. Even getting them off to sleep without killing them can be very tricky. So that there are a lot of dynamics between the pulmonary system and blowing air into people's lungs and how that affects normal cardiac function. All right. So I thought I'd give a few slides of the stuff, but not to spend a lot of detail on each one. Again, what you're seeing here, this is almost all left ventricle here. And here are the great vessels. So I always love everything. The red is oxygenated, which we're going to talk about. Blue is deoxygenated blood. So these are vessels that are leaving the heart, and here are vessels coming in. This is the ascending aorta, the aortic arch, of which there are 3 branches, as it then descends and then distributes blood systemically to the rest of the individual. here are the cava. Here's the superior vena cava blood coming from the head, and the inferior vena cava blood returning from basically everything else, everything from here down. And here what you see are the pulmonary arteries, and they are blue. It is correct, even though we use the term artery. It is, an artery connotes any vessel that is moving away from the heart. So this is leaving the right ventricle to go to the lungs. I have other photos to show you. And then the pulmonary veins are oxygenated, bringing blood back from the pulmonary circulation into the left atrium, which is barely visible here. It's this structure here. So as you can see, this is really the dominant part of the heart here is the left ventricle. And then of significant importance are the different coronary vessels. So the heart has its own vascular system, and it fills during a different portion of the cardiac cycle, which I'll show you in a moment. And when there's a lot of collateralization, which is good, because if there are any blockages to these vessels, the result is death of that area of tissue that is receiving blood, and that is what we call a myocardial infarction or heart attack, and I have some slides on that to show you. And the nice thing is small blockages can generally be compensated for because blood can find another way to the area. But if the obstruction is big enough or at a critical juncture in one of these coronary vessels, then potential catastrophe, even death, will ensue. All right. Any questions about this? So I have a picture of the back side or the posterior side. If you were standing from my back and looking forward, this is what the orientation. Again, the auricles or the atria, which I have other diagrams, are at the base, at the top, with the great vessels arising, and then this is almost all left ventricle here, and the right ventricle is kind of up behind there. And again, other coronary vessels. The coronary sinus is the main collecting chamber that is collecting all the blood that's kind of returning from the heart muscle, which actually dumps into the left atrium. And so there is a degree, there is deoxygenated blood that is returning to the oxygenated side of the heart, if you will. And that's coming from the coronary circuit, from the heart itself. All right, so let's just take the anterior view of the heart and slice it down the middle. And the point of this slide is to show you that we tend to think of the heart as like a big pump, but in actuality it's two pumps that work together. So when you may hear us talking about right heart, right-sided heart failure, left-sided heart failure, this is kind of what we're getting at. And so if you're looking here at the cava, blood coming from the head and neck, blood coming from the trunk, the flow of blood, the arrows are showing you first enter the right atrium, pass through the tricuspid valve. I'm going to talk about the valves in a moment. And then into the right ventricle. So always conceptualize ventricles are pumping chambers that are sending blood to an important place. The atria also pump, but atria are pumping blood into the ventricles, basically. And so here what you're seeing is the outflow of blood via the pulmonary artery. Again, it's an artery, but not oxygenated blood, to the pulmonary system. All right, so this is a low flow system, a low pressure system. It doesn't require a lot of pressure to send blood from the right ventricle into the pulmonary artery to the lungs. Then the blood is oxygenated. It returns via the pulmonary veins, arriving into the left atria, which then contracts and puts blood into the left ventricle, which is the primary pumping chamber of the heart, and then out through the aortic valve into the aorta and to the rest of the human being, all right? So some things in the operating room that you're familiar with, if you come and set up a swan, what you're doing with that swan line is allowing, what the attempt is that catheter is actually floated through these chambers into the pulmonary artery. And it is a way to try to indirectly measure the pressure on the left side of the heart. And so when we're interested in what's going on over here, that is an attempt to do that. And there is a lot of discussion about how well that number, does that number really tell us what we hope? And often the answer is no. If you're putting in a CVP line, or when we're putting in a central line, we're threading a catheter down to just about the right atrium. So we're looking at the pressure on this side of the heart. So the issue is, there are disorders that can cause the right side of the heart to malfunction, independent of the left, and vice versa. There can be left-sided heart failure and normal functioning right heart, or they can both be shot. And the anesthetic implications are huge as far as how you approach the anesthetic for one versus the other. And by looking at somebody's comorbid conditions, so an example would be somebody with really bad COPD is apt to have right-sided heart failure. Someone with bad liver disease is apt to have right-sided heart failure, okay? Somebody that's had a massive inferior MI, say, or some dilated cardiomyopathy, which I'm going to talk about, may have really bad left-sided heart failure. So typically the pulmonary edema thing that you may have heard about when people have fluid in the lungs is a reflection often of the left side of the heart failing, okay? Someone with big swollen legs, big giant backed up vessels, so their neck veins are swollen, is more likely to be in right-sided failure, okay? Make sense? All right, and so what this slide is just to remind you of important terminology. And this is a schematic. You'll find this in virtually every physiology textbook or some version of that. And all it's really showing you is what the two major functions of the heart. So here's right heart, and it's responsible for perfusing the pulmonary system. And then here's left heart, which is responsible for perfusing everything else, all right? And then what this schematic is, you'll see this virtually in every textbook, is kind of showing you what a capillary bed is. And capillaries are basically one cell layer thick, responsible for exchange of all gases at the cellular level, all nutrients, so your glucose, all the hormones that are going there to tell the tissues what to do, growth factors, and then they collect all the byproducts. So the carbon dioxide is put back into the bloodstream, toxic metabolites are put back in, then everything circulates back to the right heart. We breathe off the carbon dioxide, more oxygen goes in, and the cycle starts anew. So this is going, we always have to remember that the whole function of this system is to get everything that's needed for your cells to survive. All right? So if this doesn't do well, then the rest of you doesn't do well. I'm sure you've seen, you know, our multitude of half-dead people that we roll around here, that if they're in heart failure, or their heart isn't pumping well, they then start to have problems with other organ systems. Often their kidneys will begin to fail. They can develop liver disease. If they're not getting enough blood flow up to their head, they can have strokes or other, you know, abnormalities, you know, other problems with their nervous system. Okay. The other important point is that it's these terminal arteries, or you go from the big great vessels like the aorta down to much smaller arteries or arterioles that are really the gateways. And when we give drugs to raise blood pressure or lower blood pressure, it's really working at this level, at these terminal arterioles, where we can dilate them or constrict them and can kind of control the amount of blood that's getting distal to them. And the other important point is of all of the volume of blood, or if you were to like lay out all of your blood vessels from end to end, like say from here to, you know, Russia and back like 1,000 times, the vast majority is actually these capillary beds. This is where the majority of the blood is at any given time. It's spread out amongst all your cells, and the smallest portion of it is in these great vessels. All right, even though we tend to kind of think, well, that's where all the blood is, but it actually isn't. This is a diagram trying to just kind of illustrate to you the difference between arteries and veins. So arteries tend to be higher pressure system, as I've shown you in the other slides. And so the wall is much more muscular, and depending on where you are in the arterial system, there's much more innervation. Innervation meaning nerves that are coming from your autonomic and central nervous systems to tell the vessels to dilate up or constrict down. The veins are a lot thinner walled, floppier, and one of the things that veins do is they are, the term is, you may hear people talk about venous capacitance. That basically is kind of a blood reservoir, that a lot of blood can be in the venous system and kind of hang out there because it's a lower pressure, floppier system. And the veins can constrict, but really all of blood pressure regulation, and I'm going to show you some more slides on that, really has to do with the artery. All right. So when we're putting an A line in, we're going for one of these. All right, thicker, muscular, innervated vessel. All right. So another diagram just kind of saying, well, where is the blood at any given time? 84% of it is in the systemic circulation, where 7% of it is within the heart itself, and the remaining 9% is in the lung. So you got 16% heart and lung, 84% everywhere else. And then if you look about it at any given time, the majority of it is actually in the venous system. So that concept of venous capacitance, it's kind of a slower, more reservoir system that the blood is slowly moving back up to the heart. All right. All right, phew. All right, I'm keeping on time. It's like, how will I possibly cover this in one lecture? All right, so moving on, I've made references to heart valves, and so I want to spend a little more time with them because often if you're listening to us percerebrate about some patient and we're talking about somebody with mitral regurg or aortic stenosis, and certainly if you're in the heart room where they're doing valve replacement surgery, but the valve replacement thing is to fix the disorder. But often we're taking people back for other surgeries that have valvular disease. And again, if the valves aren't working right, the implications for the underlying cardiac disorder can be huge, just huge. So if I'm having a whiny day because I have somebody with severe mitral regurgitation, it's because their heart is like on its way out from the fact that the mitral valve is not working. And again, the anesthetic implications are huge. So here are two diagrams. This one I like because it's kind of showing you the anatomic relationship, where this is kind of like not really real, even though it's good to learn from because we don't generally slice the heart down the middle and take a look. So if this was the heart cut with the base taken off, what this view is looking down on it. So those of you that are in the heart room, when they drop the TEE probe and they're doing the sonar on the heart, they're getting these different views of the heart valves to see how competent the valve is, what the flow is like across the valve. We really learn a lot from the TEE. So we have kind of two kinds of valves, atrioventricular valves and nicknamed AV valve. they prevent blood from flowing backward into the atria. So here's right and left atria. So what you're seeing here is when the atria are contracting and the ventricle is relaxing, blood moves down and these valves open up. So here we have tricuspid and mitral valves here. Below this chamber would be the right ventricle, below this chamber would be the left ventricle. And so I'll show you some other diagrams of the cardiac cycle. Blood is moving down. Then as the ventricle begins to squeeze to push the blood out, either to the lung from the right ventricle or to the rest of the body from the left ventricle, these valves will just close up. And these structures here, the chorda tendineae, the papillary muscles contract, and these are kind of like, I don't know, I'm trying to think, it's like almost like a rope on a stake. It lets it go up just so much, holds the valve tight so the blood can't go backward. And then as the pressure builds in these ventricles, these semilunar valves begin to open, and they will open out this way, and blood will either flow to the lungs via the pulmonic valve or to the systemic circulation via the aortic valve. And then as the blood is done flowing and the pressure begins to fall inside here, the blood that's distal to the valve will push the valve close. And then the cycle starts all over again. So when we're listening to heart sounds, the lub-dub, lub-dub, what those sounds are the sounds of these valves closing and opening. So the first heart sound is the mitral and tricuspid valve closing. The second heart sound is the aortic and pulmonic valve closing. And by listening to heart sounds, one can discern quite a bit of information about what might be going on inside the heart. Okay, is that clear? Kind of a cool system. All right, cardiac muscle. So I was asked to touch just briefly on the cardiac conduction system. Up till now, I've been kind of talking about anatomy and just the pump, how the heart, the mechanics of the heart. And there's this other side to the heart, which is the electrical activity. And so the ECG that we're looking at is giving us an idea of what's happening electrically in the heart and how impulses are being conducted through the heart. And I'm going to spend just a little time on that, and I know you're going to have like an ECG lecture and they'll likely elaborate on this point. But I do want to say something about the cells that make up the heart muscle. This is a specialized type of muscle tissue. It's different than skeletal muscle. Skeletal muscle contracts only with voluntary impulse, meaning that something has to make it move. So when I say I'm going to bend my arm and contract my bicep, a very complex variety of signals are coming from the motor cortex in the brain, down to the spinal cord, out peripherally to the motor nerves, that then go to this muscle that say Doug wants to raise his arm, and voila, the bicep contracts. The skeletal muscle, the physiology of the contraction is the same as skeletal muscle, but the difference is these cells contract on their own. They just intrinsically begin to contract. And the reason that everything doesn't go nuts is there are specialized areas of the heart that kind of set the pace. So if you were like sculling down the river, there's somebody up front shouting stroke, stroke, stroke to get everybody in order. That's kind of what is happening in the heart. There are a specialized group of cells that are telling every other cell in the heart, this is when we're going to contract, this is when we're going to relax. So obviously, if there's confusion or something goes awry, then things can not look so good. What I do want to impress upon you, for every electrical event, there should be a resulting mechanical event. So this pumping stuff that I was telling you about, by the reason that the ventricle squeezes is that there's been an electrical signal that preceded that to tell all the cells, all right, it's time to contract. And so if the electrical system gets screwed up, then the heart may not function well, or you could even die. So VFib, Torsades point, VTAC, there's a whole list of lethal arrhythmias, and they're lethal because the electrical activity is so disorganized, the heart cannot pump effectively. If you aren't pumping effectively, you're dead in 4 minutes, basically, unless you get that all fixed up just the way you need to get it fixed up. So there are these terms. Automaticity just means that the heart will, these cells just contract on their own. I find it really interesting when we say when is their life, when is their not life, when we're talking about fetal development. These cells, if you took out cardiac muscle cells and put them in a cell culture, they would just be in the cell culture. It's just the nature of the cell. It doesn't mean that it's organized activity, it's just what the cell does. Rhythmicity is that the cells can kind of be, how should I put it, they can be corralled to do everything at once. And that pacemaker that I told you about, I'm going to show you. And so that we can then be in rhythm, that we can kind of all line up and beat at the same time. And what syncytium means is these cells are connected in a way that they function as one unit, even though there are multiple cells, that the impulses spread like lightning through all the cells at once to get this fine-tuned contraction. Okay. Yes?
Is that done via gap junctions then?
Yes.
Okay.
So they're tight gap junctions, what that's called. There are all kinds of different gap junctions between cells. So there's something very specifically different about cardiac muscle gap junction.
And all the mitochondria within the cardiac cells.
Well, there's a lot of mitochondria in, mitochondria are basically your energy producers. They're like little factories making ATPs. And so you have intense number of mitochondria in cardiac muscle because the oxygen demand is huge. So if you look at what two organs demand the most oxygen, hence whenever you think oxygen, just think blood flow, because the blood is the train to bring the oxygen to the cells, and it's brain and heart have the highest oxygen consumption. So when we're looking at SATs, or if you have a PA line in and you're looking at SVO2, which is a way of approximating what the oxygen demand of the heart is at any given time, there's a lot of information that we're distilling from those numbers about what's going on with the rest of the organism in relation to the heart. Yeah. So what this is just showing is, depending on what the pumping chamber needs to do, it will determine how thick the muscle wall is. Kind of makes sense. If you have to pump to everywhere in the body, you're going to need a lot more muscle than if you're pumping just to the lungs. All right? And the atria are even thinner because they're just pumping down into the ventricle. And in actuality, you can get by relatively well without the atria pumping at all, and just the blood filling passively both ventricles. And so individuals, if you hear us talk about AFib, that's atrial fibrillation, the atria are actually not beating, they're quivering. You can walk around with that, and most people will do fine, and some people won't, if they're dependent on that little extra volume that comes with a coordinated atrial contraction, often called the atrial kick. So typically older people, very much older people, don't tolerate AFib in the way that a younger person will.
And it explains why we do a lot more LVADs than RVADs, since it has to, it seems that way, since it needs to help with the pressure.
Well, I mean, you have to perfuse the organism, yeah. So basically, if someone's in biventricular failure, just helping out the left ventricle will often help out the right, because there's a backup in the whole system. Anyway, all right, so now in 2 minutes, we're going to talk about electrophysiology. And I'm going to change gears, and I'm not going to spend a lot of time explaining this slide because this is about 4 lectures. But I thought, you know, they're probably sometimes wondering, like, why is it every 15 minutes I have to run back and get another blood gas? You know, why are they doing that? It's driving me nuts today. I've got 30 other rooms to manage. And there is a lot about the chemistry, in particular sodium, potassium, and calcium. It has everything to do with that all-important electrical activity of the heart that I've mentioned. So basically, all this is showing is what happens to the charges between the inside of a cell and the outside of a cell at any given time. And it all has to do with the movement of these ions from the outside of the cell in or from the inside of the cell out. So typically we have way more sodium out and way more potassium actually in the cells. And we've got calcium kind of everywhere, but calcium is also a very important ion. And so to generate that electrical signal in the heart, it requires very sophisticated enzyme systems that open up, you know, subatomic sized channels in the cell wall to allow certain ions to flow in and certain to flow out. And the movement of those charges is what creates the electrical impulse that then kicks off that contraction of the heart. So if we're getting hysterical about the potassium, it's because at certain levels it becomes unfavorable to the normal relationship and can then screw up electrical activity and lead to one of these arrhythmias that we're not happy about, all right? And calcium as well. So this is why if we're giving supplemental calcium, we'll maybe be checking an ionized calcium every 20-30 minutes to see where we are, because we don't want to give too much, but we want to try to replete it, because we're trying to restore a good balance of these ions to ensure good cardiac function. So that's kind of my electrophysiology lecture in 2 minutes or less, all right? But the derangements of these are huge. So someone who's like chronically on diuretics, someone that's on another antiarrhythmic medicine like digoxin, someone who's been vomiting for a week, someone with bad diarrhea, someone with kidney failure, someone with very bad liver disease, all of these patients can begin to have derangements of these numbers, and then that can wreak havoc with cardiac function. Okay? So that's why we may be checking it a lot. All right, now, cardiac conduction 101. All of the cells that are in these chambers, atria and ventricles, remember, are made up of this cardiac muscle that I showed you a slide on that has its own ability to contract. So there has to be, as I mentioned, the guy at the head of the shell saying, all right, this is when we're going to be. And there is a coordinated system. Here are the important branches. And the pacemaker is up between the junction of the superior vena cava and the right atrium. It's called the sinoatrial node, or the SA node. This is the cardiac pacemaker, and it has a rate of firing that supersedes, in general, unless there's an issue, all of the other cells, and it kind of gets everyone going in the right direction. That electrical impulse is transmitted inside the heart to the AV node, which will hold that impulse for just a split second, allowing the atria to contract first. With these valves open, pushing blood into the ventricles, then that impulse, after it's held, will travel down the bundles of His here, the bundle of His to here, and then branch via the bundle branches to the right side of the heart and the left side of the heart. And that electrical impulse then causes the ventricles to contract, which will then close the AV valves so the blood doesn't go back into the atria, right? And the semilunar valves, the aortic and pulmonic valve, which you can't see pulmonic, this is aortic valve, will then open and blood will go to the lungs and the rest of the body respectively, all right? And then there's a resting period and it starts all over. So remember, electrical events precede mechanical events, and if there's a derangement in the electrical event, it may in some way adversely affect the mechanical events, and sometimes so severely that it may not be compatible with life, or it could at least compromise the heart from functioning normally. Purkinje fibers are just the kind of the end terminal agents. It's just kind of branching out to get to as many cardiac cells as possible to make sure everything works, all right? So when someone has a heart attack, and I have a slide for that, and part of the heart muscle dies, with it, part of the conduction system would die as well. And depending on the severity, the amount of that damage, that could wreak havoc on the normal functioning of the heart. Okay? Great. So this is another picture kind of showing the impulses spreading SA node first to the atria, then from the atria down the bundles, then the ventricles, and kind of showing you an EKG. So all an EKG is showing you is which part of the system is firing at any given time. The P wave, the first little round, is atria, and then the big QRS are ventricle, and then the T wave here is the repolarization, the resting phase, getting ready to start it all over again. So when we're looking at an ECG, we're at least assuming that's kind of what is going on. Now, if you've heard of PEA, those of you that have taken ACLS, if we have somebody with a normal ECG and we're pumping on their chest, it's like, why are you pumping on their chest if the ECG is normal? That is pulseless electrical activity. So the ECG is normal, but the heart is not responding to the electrical signal. So you can have a normal ECG and still be dead, and it happens sometimes. All right, I'm going to talk about the cardiac cycle, and I'm going to see how much further I get in the time allotted. Very important words. Systole just means the contraction of a muscle in the heart, atria or ventricle. You can have atrial systole, ventricular systole. Diastole is the opposite, it's the relaxation. Stroke volume is the amount of blood pumped with each beat. So when we're talking about stroke volume, it's we're talking about the left ventricle and the amount of volume of blood that's pumped with each squeeze. And the cardiac output is the amount of blood that is pumped generally over 1 minute. The cardiac output is in terms of a minute of pumping, all right? So these are numbers I'm sure you're hearing us talk about all the time. And so to remind you what blood pressure is, because this is a pressurized system, all blood pressure is the amount of force against the arterial walls. So with each beat, there is a pressure generated to make that blood flow, and that pressure is transmitted across the arterial wall, and that is what blood pressure is. That's what we're looking at. So I'm leading up to this incredibly complex slide that I can't spend a lot of time on, but I'm happy to distribute this for your reading pleasure. This basically is putting everything together. So in just a real quickie here, this is the ECG, this is the electrical signal. This would be what you would hear if you put the stethoscope on and you were listening to somebody's heartbeat. These are pressure waves. You're very familiar with them, in particular A lines, which are much more common than PA lines unless you're in the heart room. What we're looking at is the pressure wave generated. That A line is really showing you the pressure wave generated by that left ventricle pumping. You know, if the A line is in the radial artery in the arm, you're looking at the pressure wave coming down that artery, all right? And so that pressure wave is from here, this is diastole, here's the left ventricle pumping, pressure goes up, it comes down and it pops up again. The dicrotic notch is a reflection of the aortic valve closing. That's another lecture to explain why it looks that way. And then it kind of slides down again and starts all over. What you're seeing here are what's happening in the atria. And then here are just the volumes inside the ventricle. So as the ventricle is filling up while it's relaxing, then it squeezes and pushes the blood out. This is the stroke volume. And then it begins to relax and fill again, all right? And then what these pictures are showing is what's happening inside the heart at any given time, and this is telling you which valves are open and which valves are closed. So believe it or not, when we throw a stethoscope onto somebody's heart and we're listening, that is, and if we're listening for a murmur, that might be telling us something. We're listening for the valves. We're looking at their blood pressure. We're looking at the arterial waveform. If there's a PA line in, other calculations are being done, actually measuring the cardiac output, the amount of blood that's flowing per minute by that catheter. That's how we are interpreting all of this information to get a sense of how is that heart functioning. So that's what's happening with that. And even with an A-line, a lot of this information can be elucidated. So some formulas here that we use very commonly are, we can just do the math. If you can look at someone's stroke volume, you can then take the stroke volume, which is an average of about 70 cc's per beat, and multiply that by how many beats per minute and know what the cardiac output is. So this is just kind of showing you that the average adult has a cardiac output, something around, I'm sorry, this should be liters, not mils. So it's about 5 liters per minute, give or take. All right? So that's how, so if the heart rate goes up and the stroke volume stays the same, the cardiac output would go up. If the heart rate goes down and the stroke volume stays the same, the cardiac output would go down. But stroke volume could go up or down and heart rate could stay the same. So often the drugs that we're using are manipulating one or the other, or both, to try and maximize cardiac output. All right? And I'm going to skip this because I'm going to run out of time. So I just want to show one other slide here and then a few little disease slides and then we'll stop. If we're looking at cardiac output, the things that we're doing in the operating room are manipulating many factors that affect the outcome. And what preload is, if you hear us talk about preload or what is preload or he needs more preload, you know, we're talking about the amount of volume. EDV is end diastolic volume, the amount of volume that is in that ventricle right before it pumps at the end of diastole. And so by giving preload, think of a rubber band. As you stretch it and then let go of it, the more you stretch it, the harder it hurts, right, on your hand. That contraction of the rubber band gets more powerful. So the concept here is that as you make that ventricle stretch a bit, it will push harder. Hence, the strength of contraction goes up, the stroke volume goes up. So someone who is dry, that ventricle isn't very full, is going to have reduced stroke volume, reduced cardiac output, and then reduced blood pressure. Because remember, this is all about blood pressure, ultimately. However, if that ventricle gets too full, imagine pulling that rubber band to the point that then you've overstretched it, and obviously it would break, but let's say that it didn't, you just stretched it out and then it's kind of floppy. That would not have a very strong bounce back, right? That's really, in a way, for certain people what heart failure is. That the ventricle just gets so big from being stretched for a variety of reasons that it no longer can beat well, resulting in impaired cardiac output, and depending on how severely dysfunctional that ventricle is, they may end up getting an LVAD, ventricular assist device, or one of the zillions of therapies that we use to try to improve that. But then there are other things that can affect the blood pressure by either changing the heart rate. Remember, bringing it up sometimes will help, as long as it's not too fast. The heart rate is too fast, the ventricle doesn't have enough time to relax to fill, and then stroke volume will go down. And then there are all these chemicals, so epinephrine, which we make endogenously, many of the other pressors, when we ask for like a norepi drip, things like that are actually directly and indirectly affecting the heart muscle and how it squeezes, as well as how tight the vessels are. And I'm going to finish with that, this concept of afterload or vascular resistance is really how much pressure that heart is pumping against as blood is coming out, all right? And that term is afterload, all right? And we need to have some resistance, some tightness to keep our blood pressure, but if it gets too tight, that ventricle has to work too hard to push the blood out of it, and it can begin to fail. And the way that I like this picture, because it's kind of showing, here's the blood coming out of the heart into this kind of artery that has some ability to distend itself. And then depending on how you pinch off the end of it is going to determine the force that's going through that. And if it gets tight, the pressure starts to go up in here. But if it gets too tight, the blood will no longer be able to flow through it. All right, so for example, phenylephrine is a drug that we use to help tighten these vessels. And it will raise the resistance, but in somebody with a bad heart, it might not be a good choice because it'll make the heart work too hard to get the blood out. All right. When we use a PA catheter, we're actually able to calculate what the resistance is in the total arterial tree to get a sense of whether or not we need to adjust that to max